thanks for joining, and I'm going to spend the next 15 or 20 minutes talking through a few slides on salivary adenocarcinoma. And as a brief introduction, I'm Rob Metcalf, a medical oncologist at the Christie in Manchester, UK, and I've got a particular focus on treating patients with salivary cancers. Slide 2. So just as a brief introduction, so when we're talking about salivary gland cancers, what are we talking about? So there are three major salivary glands: the parotid, the submandibular, and sublingual. And these are, there are three pairs. There is one on the left and one on the right. So they're what we call major salivary glands. There are also minor salivary glands. So the minor glands are just small, microscopic glandular structures that are found throughout the head and neck region. And you also find them actually down in the airway, so in the trachea and proximal bronchi as well. The function of the salivary glands is to, as the name suggests, to produce and secrete saliva. But something that we often talk about with our patient group is that salivary gland type cancers, so the same histologies, the same cancer types, can actually arise in other parts of the body. And so, the commonest cancer type that I manage is adenoid cystic carcinoma, and that can arise in any secretory gland in the body. Today's talk is about adenocarcinoma, and so people may be familiar with the term adenocarcinoma because actually almost any organ can have a cancer type of adenocarcinoma arising within the glandular structure of that organ. So but for the message though about salivary type cancers, they can arise anywhere in the body as well as in the major salivary glands. So the structure of the salivary glands. So this is a sort of a picture of what the gland would look like under the microscope. So it has different component parts. So this is the main functional part of the salivary gland that produces saliva, the acina or the acinus. It secretes the saliva into these ductal regions, which then go through to other ducts to be change their makeup before they are secreted out into the saliva. So you have acini, you have a ductal system, and then you also have these supportive tissues. So the around the outside of these cells that make up the ducts, you have cell types like myoepithelial cells or fibroblasts or even immune cells that produce the other sort of component parts of the salivary gland. And all of these different cell types can give rise to cancer. I'm just changing the slide. Go on for some reason. There we go. So salivary gland adenocarcinoma. So head and neck cancers are relatively uncommon compared to most cancer types. Salivary gland cancers are a rare subtype of head and neck cancer, and then adenocarcinoma is a rare subtype of salivary gland cancer. And so as reflected in the room today, there aren't many people out there who will have the diagnostic label of salivary gland adenocarcinoma. Just to expand on what we mean though by adenocarcinoma, so how does this label get applied? In the next few slides, we descend a little bit into what is described as histology or histopathology, just to explain why this label of adenocarcinoma gets applied rather than some other label. And then we'll talk a little bit more about what that means. So adenocarcinoma, carcinoma means malignant, it means cancerous, and adeno means glandular. And so an adenocarcinoma is a type of cancer that arises from glandular tissue or glandular structures. And then if it's a salivary gland adenocarcinoma, it just means a cancer that arises from the glandular tissue. And so, as you can sort of work out, it's rather a generic, when the previous slide I showed you that there are many different cell types that make up the gland that is the salivary gland. As I said, it's rare, and the purpose of today's talk is just to give you an overview, really, of where adenocarcinoma fits into all of these other subtypes of salivary gland cancer, to try and understand a bit better about this diagnosis and how the label impacts on treatment options. So when a pathologist looks down the microscope, they look for different features to give the label of adenocarcinoma. So these are the things they're looking for: invasive cancer cells forming nests with large nuclei, relatively, so the nuclei shown here in purple, relatively less cytoplasm, little holes, little vacuoles, these little speckles in the nuclei, prominent nucleoli, and then you can get these glandular structures. So this is what a pathologist is looking for to give a label of adenocarcinoma. So they're looking for malignant cellular appearances, that's these things, and then glandular structures forming within the malignant cells. So these aren't normal structures, but these are malignant glandular structures. And so how does this differ from other histologies? So I've got two examples, and the caveat here is I'm not a histopathologist, but I understand what they're looking at. But here's two other examples. This is an acinic cell carcinoma at the top. This is an adenoid cystic carcinoma at the bottom. And so you get different appearances histologically for different subtypes of salivary cancers. So here's 3 of the 24 examples of different histopathologies of salivary cancers: mucoepidermoid, adenoid, cystic, and acinic cell, and they all have different distinct appearances histologically. So if we take a step back, though, what is the one, how are patients managed? Well, actually, irrespective of the histology, the same sort of diagnostic workup happens. So patients will have their initial clinical assessment. So they will have a history, have an examination. They will then have imaging with normally CT, MRI, or PET, and then they will have a biopsy. So all of that is pretty standard, really, irrespective of the different histology. Then each patient will be given staging using often this TNM classification. So you stage the tumor with a T number, you stage the lymph nodes with an N number, and you stage whether lymph nodes are present or absent, so metastases are present or absent, with an M number. And again, the staging is pretty consistent across all different salivary histologies. So you get you get the same TNM stages. One of the purposes of TNM staging is to inform the risk of recurrence. So it informs on, after surgery, what post-operative treatment is needed. Do you benefit from adjuvant radiotherapy? We don't really have any situations in salivary cancers where we give post-operative or adjuvant drug therapy, but it informs on the risk of future recurrence or survival. And although I'm a medical oncologist, again, these are just standard principles of oncology management, and surgery is the mainstay of treatment for patients with any salivary cancer, including salivary adenocarcinoma. So anybody who has a localized tumor, so a tumor that arises within the salivary gland, and it can have local or regional lymph node spread, but no confirmed spread anywhere else, then surgery will be the gold standard primary treatment, aiming to completely resect the disease with curative intent. In the localized disease setting, then radiation therapy, described as adjuvant, meaning as an adjuvant treatment being post-operative, is given to tumors that are high risk of recurrence. And then, as I said, there's no established role for drug therapies in the curative setting. But in my patient group, which is predominantly patients with recurrent or metastatic disease, that's where different drug therapies have different roles depending on the subtypes. As I was saying, prognosis is dependent upon tumor grade, stage, and then different molecular features of the tumor. But for patients with localized disease, it depends on, it's influenced by stage and grade predominantly, but the majority of patients are cured with localized disease. And I think that's important for me to emphasize when I go on to talk about drug therapy in the recurrent metastatic setting. However, patients who do have advanced stage, inoperable or recurrent metastatic disease, they do have relatively few standard of care, established therapies, and their survival is significantly worse than patients who have curable or surgically resectable disease. So in salivary gland adenocarcinoma, what is molecular pathology or molecular profiling? So, I mean, yeah, some people in the room, I guess, will know about, what a cell is made up of, but just to think about that, every cancer will contain billions or trillions of cells, depending on the size of the cancer. Each cell would have a nucleus within it. Within the nucleus, there will be DNA packaged into chromosomes. Then as you sort of unravel the DNA, you can see these different nucleotides. And one way of sort of characterizing tumors in more detail beyond the sort of pink and purple staining that histopathologists do is looking at the DNA for different mutations, particularly if those mutations are then potentially drug targets. So in adenocarcinoma, you can see, so there are a family of genes called RAS. This is an area of research. There aren't established RAS therapies in salivary cancers, but there's a lot of research looking at targeting the RAS gene family, and that would be potentially in a tumor agnostic way. So for instance, colorectal cancer, pancreatic cancer, lung cancer, these RAS genes have got a role to play in a significant proportion of them. And so there's loads of research that we can take from other cancer types and potentially, when it comes to developing new treatments, apply to our patients with salivary cancers if, for instance, they have RAS gene mutations. So HER2 is another gene that is amplified sometimes in salivary adenocarcinoma. So normally we see HER2 amplification in a different histopathology called salivary duct carcinoma, where it's overexpressed in about a third of cases. But there are a proportion of patients with salivary adenocarcinoma who will have HER2 amplification. I think it's open to interpretation as to whether those patients actually perhaps have a salivary duct carcinoma that just doesn't look the same as most other patients, but it might actually be that it's just diverged or become less well differentiated, and so has been labeled adenocarcinoma, but in fact it may be a salivary duct carcinoma. The relevance of HER2 is there are a number of therapies targeting HER2 that have been proven in breast cancer initially, and then some of them have been studied then in patients with HER2 overexpressed salivary gland cancers, including salivary adenocarcinoma, where you see a similar proportion of patients responding as we see in breast cancer. So we have far less evidence in terms of, we don't have the large randomized studies, so it's much more difficult for them to have been, or to be considered a standard of care, but I think they are increasingly considered a reasonable standard of care actually in patients with HER2 overexpressed salivary gland cancers, and so it's something that is worth looking for. Again, another gene, PIK3CA, is so a small subset of salivary gland adenocarcinomas will have a mutation in this PIK3CA mutation, and there are new therapies in trials targeting PIK3CA. And then there are rarer mutations which are less easily or less directly drugged, but may be useful in matching patients to trials sort of targeting particular pathways. So this concept of molecular profiling, so sequencing tumors, is useful because it potentially identifies what we call actionable mutations, so mutations you can actually do something about, and it can help tailor treatment plans for patients really with advanced disease, so recurrent or metastatic disease. And so, as I said earlier, this doesn't take away from patients who have localized disease, surgery with or without radiotherapy being the gold standard, but patients with advanced, so metastatic disease, and that's where this increasingly has a role. And so I've talked about some therapies. I think just to talk through the figure first, from my perspective, I think there are some drugs which can be obtained outside of trials, but there are probably most new treatments in salivary gland cancers are still going to be obtained within trials. So just a brief sort of word on what the sort of trial phases are and where salivary gland patients might fit into this. The phase 1 trials are the first phase of a drug's development. So this is when you have a relatively small number of patients, maybe up to 30 in total. The purpose of a phase 1 trial is actually to define the drug's dosing and to define the drug's safety and to determine the recommended dose to be taken onto a phase 2 dose. So in many respects, these are actually the least appealing studies for patients to go into, because the way the studies are designed, the first patients in the first cohort are often getting a fraction of the expected effective dose. So you might start at, say, 1/10 the predicted effective dose. And then the first 3 patients, once they've been treated, will actually normally stay on that dose. The next 3 patients will go in at the next dose level up, and then the next 3 patients at the next dose level up. And eventually you get to the dose level that you take through to phase 2, based on seeing that it is tolerated, it doesn't have an unacceptable safety signal in a small number of patients, and that hopefully you see a signal of it doing something. But in a phase 1 study, you don't often expect to see a signal of activity, a signal of tumor shrinkage. Phase 1 studies then run into a phase 2 where you might narrow down your sort of target population. You want to give a larger number of patients the study. In the figure there, it says 100 plus. In reality, in salivary cancer, the number is normally about 30 to 80. The purpose of a phase 2 is to understand your safety signal and to confirm whether there truly is a signal of activity. Now, phase 3 is when you're looking at large numbers of patients, randomizing to a standard of care versus your new drug. In reality, for most patients with salivary cancer, if they're going to get access to a drug on a trial, it's either going to be a phase 1 or a phase 2, partly because there are just insufficient patients to ever conduct a phase 3, or it's not entirely impossible, but it makes it almost impossible. And partly because, particularly in phase 1, most studies will permit patients with any tumor type. They don't have to have a specific tumor normally. So so you don't have to have a study that is specifically designed for patients with salivary cancers, for salivary cancer patients to go into that study. So there are more opportunities for patients in phase 1. Phase 2, there are relatively fewer, but they are, I would say, the best studies for patients to be going into from their perspective in terms of the chance of benefit and the confidence in the safety signal. So it's a bit of a talk around clinical trial design there, but I think it's just to make the point that most new therapies will be accessed and given within clinical trials. On the left, I've talked briefly previously about HER2 and PI3 kinase targeting therapies. So immune checkpoint inhibitors, I think many patients are aware of immune checkpoint inhibitors. We often don't really talk about it in our patient group because actually, as I said earlier, most patients have adenoid cystic carcinoma where the data for immune checkpoint inhibitor therapy, it doesn't show any meaningful signal. However, for patients with salivary gland cancers that overexpress PD-L1, and patients with adenocarcinoma will fall within that, there is some data on pembrolizumab. I think the response rates are around 12%, meaning 12% of patients getting tumor shrinkage. That's actually quite low. compared to head and neck cancers, where you see about, approaching 20% of patients having tumor shrinkage, but it's not zero. So there is a signal of some patients benefiting. And it is possible that patients with adenocarcinoma may be those that are more likely to benefit, although I would say we don't know. But I think where the drug is available globally, the first step is to check for PD-L1 expression. And then, just to finalize, to come back to clinical trials, I mean, the other reason I think clinical trials are so important is if we are going to change things for our patients, for the person in front of you, just getting the drug to that person is clearly the most important thing. But actually, for us to change things systemically for all patients, across the UK, but anywhere in the world, it's getting patients into trials and onto new treatments is the most important thing. So that's why I kind of emphasize that point there. So that's my kind of whistle stop 15-20 minutes on salivary gland adenocarcinoma. Many of the things are actually, many of the sort of aspects of treatment that I've discussed are transferable from one tumor type or one salivary gland type to another. And I think what I've probably tried to do is just explain a bit about how this label of adenocarcinoma comes about and why we do describe it differently to other subtypes that we see more commonly. So I'll end there, and then maybe we can have some time for discussion.